So welcome everyone to this She Presents session where we have 5 interesting proposals to listen to. My name is Danielle Verstegen. I'm Associate Professor and She Educates Lead in Maastricht. I'll be presenting today and I will give each of you 10 minutes to present and 5 minutes for questions or whatever you prefer, about 15 minutes in total. Any questions before we start? And if not, I think Beatrice, could you start sharing your slides and I can announce our first presenter, Beatrice Preti, who will be talking about saving face, losing yourself. The floor is yours.
Thank you very much. And hello everyone, it's an absolute honor to have the opportunity today to share with you my early PhD work in impression management and moral distress. By way of introduction, my name is Beatrice. By training, I'm a gastrointestinal medical oncologist. I'm currently based out of Atlanta in the United States, Emory University. I also have an appointment with Western University in Canada where I trained. And of course, I'm a PhD student with Maastricht. I have the opportunity to work with fantastic Eric Dreesen from Maastricht, Jacqueline Torti, who is from Western, and Doreen Balmer, who is from UPenn in the United States. So for those a little less familiar with the concepts of impression management and moral distress, impression management comes to us from the 1960s sociology literature. A man called Goffman, who noted that humans have this theatrical performance they engage in with each other, where they're projecting thoughts, attitudes, beliefs, even engaging in actions that don't align with what they actually feel inside. Now we can imagine how impression management permeates a lot of aspects of our lives. All we have to do is think about social media or the internet. But the original Goffman work actually noted that medicine was a field where impression management was quite rampant. Doctors and nurses project things to patients that aren't accurate reflections of what they're feeling inside. And while this may coincide with professional norms or duty to the patient, healthcare workers also engage in impression management a fair bit with each other. Now, going to the education side of things, impression management has been noted in medical education in a number of different facets. Things like evaluations and feedback conversations, saving face, or this idea of faking it till you make it, a form of professional identity formation. Interviews and application culture. I think when we're all applying for a job, we do put on a little bit of an impression and we try to manage the image we're making. But there is documentation out there that medical trainees may go so far as to falsify information in an effort to really present a certain image of themselves. And then medical culture as a whole, medical learners may find that they conform, comply, and obey medical cultural directives or norms that don't align with things that they feel personally or may embody in their own personal lives. So on the flip side, we have moral distress. Moral distress is a concept that comes to us from the 1980s nursing literature. This idea that people can have an undesirable psychological or emotional reaction when they're not able to do what they see as morally correct. And this can come in a couple different forms. On one hand, we may have two equally correct things that we need to do in the moment, but we can only do one. So you think about working triage, for example, you have two equally sick patients. Morally, you want to give them both the best care, but you only have one bed. So you have to pick one to go back now and then hope that the other one does okay. Another example of moral distress can occur when we want to do something that we see as correct, but something external, like a government regulation or an institutional policy, is preventing us from doing that. So moral distress is really individualized, and the way that an individual person perceives or feels moral distress can differ. We can see things like disengagement, powerlessness, hopelessness, anger, frustration, guilt, and despair. And not just at the situation at hand, this can spill over to other areas of both professional and non-professional life. Withdrawal from the situation, withdrawal from others. Then over time and over periods of repeated moral distress, things like disenfranchised morality. Because if someone is constantly telling you what you feel, what you think and what you feel matters, or sorry, what you think is right doesn't matter, because you're going to be told what's right and you're going to be told what you can do, you're going to start to lose touch with your own sense of right and wrong. And then things like burnout and psychological distress as well. Now, we know moral distress from the literature is inevitable in medicine. When you take well-meaning, kind-hearted, morally upstanding people, healthcare workers, and put them in systems with restraints, with limitations, where they can't function the way they want to, they're going to have moral distress. We also know that our learners are not exempt from this. They see the constraints, they see the limitations, and they too are affected by it. But linking this back to impression management, we end up with an interesting scale. Because on one hand, as children, we're taught that lying is wrong, right? That you always want to tell the truth, that you want to be authentic, you want to be true to yourself, right? On the flip side, we know as adults that's not 100% true. 100% of the time, you don't want to be telling the complete truth all the time, and you're probably going to get yourself into trouble. So where do you draw the line, right? And how do the scales tip where you're engaging in moral impression management that you think is morally correct versus not morally correct? There's also evidence out there that impression management can be used to help resolve moral distress. And with this, we have the first question of my maybe 4-study trajectory. How do impression management and moral distress interact in medical students, if at all? Picking medical students because they are the most vulnerable, the lowest on the totem pole of medical learners, and the freshest, closest to lay people. So we're using a qualitative approach, specifically constructivist grounded theory, conducting one-on-one interviews with medical students based in the United States and Canada, just because these students, it's not direct entry after high school. They will have university degrees, sometimes masters, PhDs, second careers. So coming at it a bit more seasoned. Currently, we're in the recruitment stage. We did perform a pilot interview and a second pilot/first participant. Some very early trends from only 2 interviews that we do want to chase further is where exactly the impression management directives are coming from, whether it's the hidden or the formal curriculum, because we're starting to see a mixture of both. It's also interesting that we're starting to see not so much moral distress, but a bit of a moral directive, where the students are telling us that the most important thing for them is to succeed in medical school and to become a doctor and to do whatever it is that they set out to do in the first place. And if this impression management and painting themselves of a picture this way or that way is what's needed in order to get there, then that's what they're going to do in order to get there. So definitely things to explore further in this study. In future studies, hoping to probably capture the postgraduate side of things, which seems the next logical step. Possibly faculty, we haven't decided as yet. And ultimately having some sort of curricular intervention, perhaps using improvised theatre, to try and bring this less from the hidden curriculum and less from individual side of things to the outside of the shadows, where we can speak openly about these things that everyone is going through. Everyone uses impression management, everyone experiences moral distress. So how can we speak about this and try and come to some sort of shared understanding, shared expectations? So with that, if you're interested in following along the journey, here's my contact information, and I'd love any questions or feedback or thoughts anybody might have. Thank you so much for your time.
Thank you for sticking within that time impression. Yeah, I'm impressed, I would say. Who can I give the floor for a question? And while you're thinking then, think of a question, all of you. Can I ask Beatrice, is this moral distress, is this something that you link to what happens in clinical workplaces, or would students also have moral distress before they get there?
Yeah, so that's actually another one of the trends that we're seeing, because some of our participants haven't done a lot of clinical work by virtue of being medical students. Initially, and in the literature, a lot of the moral distress is coming from clinical work. However, a lot of the scenarios that are being relayed to us are preclinical, so classroom-based, so application-based, so extracurricular-based, not even within the formal medical school curriculum. And I think all of this does contribute to a student's experience and what a student is learning about the field of medicine. So it's something that we're going to be exploring, really both sides.
Juan, you are first on the list.
Yes, thank you for the nice presentation. A very interesting topic. You mentioned you are going to recruit more participants probably after the pilot. I was just curious, how do you think you're going to approach it to recruiting participants? Because I can imagine this could be also a topic a little bit sensitive and personal to students. So just, yeah.
Yes, absolutely. So I always find recruitment a little challenging with these studies. We're approaching it through email and then snowballing. So I know a lot of the students personally. So when we're sending out the email saying, hey, it's just me. Do you have any friends who might be willing to talk to us? And the way we're pitching it is we're not saying impression management and moral distress. We're saying, do you want to talk? We want to talk about situations where you felt you had to present or you couldn't present aspects of yourself. Maybe there's a question of right or wrong. Students, I think, are more eager to talk about that. And what we found in the pilot, our students are particularly eager to, let me tell you about this time a classmate lied to the preceptor. So I think it's kind of how you present it to them.
Yeah, nice. Thank you.
Thank you. I'm going to give Anna the word before I go to the staff. Anna, we can't hear you. You have to unmute.
I was just laughing that I jumped the line. Thank you. I have met Beatrice, and she and I have thematically adjacent work. So I was really excited to see how you developed it since I saw you present at the collaboratory at CHOP. I was going to ask you whether you personally are doing these interviews, since we're also asking questions that are a little bit hard for trainees to answer, and the medical students are even lower, as you say, on the totem pole. And I'm very impressed that you got someone to tell you a story about when they lied, because that's requires pretty significant vulnerability.
Yeah, absolutely. So I think part of the trouble is, in the ideal space, we'd have a medical student, but because it's PhD work, I think technically I have to do most of it myself. The way we're approaching this is I actually start off the interview with a not recorded conversation, and I'm using a lot of self-disclosure. So I actually tell them about the situation where when I was going through the residency match, my body was putting false information and making up family members that didn't exist to have a personal connection to the cities that we were in. And so using that as an example, and then it often gets the students to say, oh yeah, I have a buddy who did that too. So really trying to lower the hierarchy and really just have a conversation. Of course, maybe with a student, they would be more forthcoming, but I think they are getting increasingly forthcoming as we go.
So cool.
Janneke.
Yes, thank you, Beatrice, and nice to see you in person, more or less. Nice to see many of you that I've only been in touch with by email, but nice to see your faces now. And apologies that I have to leave the session earlier, but looking forward to seeing all the presentations as they are recorded. Thank you for your presentation, Beatrice. I think it's a really intriguing topic for everyone because we all deal with these kind of situations, and as you mentioned in your presentation, it's very individual how someone experiences this and how they then take decisions on what to disclose or how to do that. I was wondering, and I think this goes for so many of our studies, how you are balancing the individual experiences that your participants will have with your approach of constructivist grounded theory, in which you do try to come up with a certain theory that may be transferable to other contexts. So I was just wondering about your thoughts, but this may count for other studies that will be presented in this afternoon as well. What are your thoughts on that?
Absolutely. So I think there's a couple of things. One is that our recruitment is starting in two very different universities. We have a mid-sized Canadian university and a smaller university town. And then we have a metro American university that's currently quite highly politicized, a lot of chaos going on. So the experiences of the students in the two groups, based on previous studies we've done, are actually quite different. So if you can look for the similarities in their experience, though, I think that that's quite transferable to a number of different contexts, because you have this international slant, the different vibe from the two institutions, the different values of the two institutions as well. And I think also ensuring that you have a diverse population, you know, students from different backgrounds, students of different ages, students of different demographics, because again, things like morality and pressure management is very individualized. So the more diverse that you can get, and then looking for the commonalities in their experience, I think the more likely you are to find something that's transferable more broadly.
Yeah, thanks. And I think it's also nice to still emphasize the differences as well,
Of course.
apart from the similarities. Looking forward to your results.
Thank you.
So, Pascal, if you have a short question, you may ask.
Very short. I was just wondering, very short. A very nice story, by the way. Love the topic. I was just wondering this moral distress that comes from impression management. I was just wondering. So the example that you just gave seemed to me a sort of ethical dilemma that that you may experience. So to what extent is this moral distress actually different from the usual ethical dilemmas that we come across on a daily basis?
Absolutely. So moral distress comes from an ethical dilemma or a moral conflict, I guess, if we're using morality. Not all moral conflicts lead to distress. So in the situation that I described, the distress is more that I'm witnessing someone do something that I feel is incorrect. And then I'm left with the question of, am I going to do the same thing as them? You know, do something that I feel is incorrect to try and get ahead or match, you know, their impression that they're making, or am I going to stay true to myself? So you can have that experience with that question without the distress, but if you do have distress, that's what makes it moral distress.
Okay, thanks.
Okay. I'm going to ask Jannie to start sharing her slides.
Yeah.
And I'm already announcing to the rest of you that I will get back to you to ask questions to Jannie. So please, when you listen, make sure that you have some questions. Thank you, Beatrice.
So I'm not really good in Zoom. So normally I always work with
Teams.
Teams. Yes. So I hope this will work. Maybe
We have, and otherwise we can do some improv theater. I'm really. That was my other question I was going to ask. Why improv theater? But we see Jannie's slides, so.
Yeah, and I have to.
Yeah, you have to share that.
Present, yeah. So like this. Yes. So I'm really happy to tell something about my research. I just started with my research on holistic validation of work experience of long-time students. So the focus is on long-time students. I'm Jannie Lensen, and I work on the Windesheim University in Zwolle in the Netherlands. And I do my PhD in the University of Maastricht. The central thought of this is transfer informal learning to formal learning. We have to deal in the Netherlands and probably also in other countries. We have to deal with a lot of students, 20% of the students who did not finish their study, yet they are still member of the university, but already working in the field of education. So that's really special. So they are working as full-time students, full-time lecturers, full-time teachers, and they get a full-time salary, but still are not fully they don't have a full education yet. And I was wondering, what is the cause of their long-time study? So I tried to get some answers in this study. I see that teachers institutes are struggling with this. They are really trying to find a way how to treat them in a well way. At this moment, it's really difficult. And I assume that there is no alignment between teachers' education and the professional field. Something is going wrong in that situation. So my research question is, to what extent can long-time students be to successfully complete their teacher education program through holistic validation of their experience? That's important for me to find out. And I think my institute and also other institutes in the Netherlands has to do something with that. So first I want to find out what is the real reason of long-time study. The second is the guideline of we want to make some guidelines from holistic evaluation of work experience. So we want to find out how, what are the requirements in the working field, and is it connected to that what we want to see in the university? Because in the teachers' education, we make some learning outcomes, and probably there is a difference in that. So we want to validate, we want to do assessments with these long-time students. And at the end, we want to know what is the experiences and the effect of this intervention, what we make. Now, I use the educational research design, and here is the 4 studies. So the first study is the causes of the long-time study students. The second is, and the red circle is the intervention. So we develop an intervention and we carry out this intervention with assessments. And at the end, we want to evaluate the policy, we want to evaluate the effects on the students. So probably they have a better way to end their studies in this way. The target group is 35 long-time students from Windesheim and from Utrecht University. And the students are more than 5 years already students. Normally it's 4 years, but 5 years or more. And they are working for more than 0.5 FTE. That is the full-time access, full-time way of teaching. There are 15 stakeholders, managers, examination boards, lecturers, and also the director of our institute. So we try to find what is the reason and how do they handle the long-time students at this moment. Now, in the study 1, I'm in now, there are some students courses from long-time students, teacher training and working fields. Now, for example, the students with the procrastination, the traumatic experiences, negative self-esteem, the student skills, motivation, private circumstances. The teachers, the Teacher Training Institute probably has also some courses. A change of a coach, a change of a program, the guiding is not fitting well with the student. And in the working field, I saw already in a previous research, I saw already something. The students are full-time working sometimes. It's really hard for them to study. They don't have time. And they get already their full-time salary. So why would they end up their studies? The position of the teacher, and sometimes there is no guiding coach in the field. So probably that could be a reason that they cannot end their study. But I want to find out. In this study, there are several, I faced several stages. The ethical committee, they have to agree with the proposal, and they almost are there, maybe next week. And then I made already a questionnaire for different stakeholders, so I can start very, very quick at this moment. The presentation of this research to the department chairs, and then the selection of the students and all the stakeholders, agreement of the students, signing a document, making an appointment, interviewing the students, transfer audio to transcripted text and analyze this text, the qualitative analyze, coding and finding the topics and describe the results. So this is my research at this moment, and this is my address if you have some more questions or if you want to contact me. It's always possible because I'm really involved in this topic. And maybe you have some questions. Thank you for listening.
Thank you for presenting, Jannie. And maybe to clarify for some of our listeners, Jannie's research is situated in teacher training, not in educational and not in the health teachers for primary, secondary, and vocational schools, I understand.
Yes.
Right?
Yes. Yes. Oh,
Yeah.
and I forgot to say that my promoter is Professor Desiree Joosten from University of Maastricht, and my co-promoter is Ruud Duvekort from Utrecht. Yeah.
Questions to Jannie? Chris.
Well, thank you for a nice presentation. Very interesting. I do recognize the problem within medical education as well, with the students don't seem to progress and having conversation over conversation and to get them until the end. Well, the advantage in medical education is that they cannot become a doctor before they finish their school, of course. My question is about the design. I think it's very useful to progress to meaningful ends. It also consists of theory building. I was wondering, what kind of theory do you want to build? What do you foresee to come across?
Thank you for this question. So I think the theory, what I'm focusing on at this moment is holistic validation. So Ruud Duvekort is writing a lot about that, also international, and I'm also a member of a group of people who are working with holistic validation all over the world. So that's really interesting. And the other thing is I'm a psychologist as well. So I'm really curious about the courses of the long time study. Why do they study so long? What is in their mind? So I'm looking at every kind of possibility. And that makes me very interesting in the former presentation as well, because I'm also working, for example, with the way how people are treated. So it's connected to our last presentation from Anna. I work with transactional analysis very much in my profession as a psychologist, and also I see that if you are on the same level with people, then it's more easy to guide people. So in the construction of the assessment, I try to use that theory as well. Yeah.
Interesting. Thank you.
Yeah, I see a parallel with I'm working with a colleague who works on informal and incidental learning. And there's a clear parallel to those theories as well. So
yeah,
she's going to be here in May. I might get you in contact with her.
Oh, that's great. That's great. Yeah.
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 Anna, your question.
This is so interesting. Thank you so much. And my question, I think, likely reflects my lack of understanding about holistic validation generally, but I was curious, since we, on the health professions education side, really think about sort of when we're doing validity studies, think about like what are the types of validity evidence that we're gathering. I was just curious, sort of from the method of holistic validity, what are you looking for? What are the outcomes there?
Thank you for this good question. I think this is my research as well. So normally there is an analytic way of validating the knowledge. So you have a list of things you have to know, learning outcomes, and now you can point out what they already know. It's analytic. And now we want to change that in holistic. So we want to find a way if they can make the transfer from their working experience to the skills they need in the education direction. So they learn so much. It's the informal learning. It's the way they learn in the working field, hands-on. They learn so much, and probably you can find in an assessment if they can make the transfer to what they really need for the education. But at the other hand, I'm a little bit worried that there is no alignment between what the teacher education developers think they have to know for the working field. And of course, there is communication. We have a lot of development groups together with the working field, but I can imagine that there is a huge gap between the things the practice ask from the students when they are teacher in their full job and the education. And you know, so many times they have to follow every module, every part, every cluster of activities in the university, and at the end they can maybe make a good assessment. But now we want to turn it all over again, and we want to let them prove that they are already ready to work in the fields. That's what we want to prove. But yeah, it's a little bit, so the transfer is the central word, the transfer of what you already learned in the practice. Yeah. Thank you for the question.
Thank you for that beautiful presentation. And I think we're all looking forward to seeing how we can recognize the learning that people do outside of our institutions, right? Yeah. Let's go over to our next presenter. That's Anna Weiss in this occasion, and she's going to talk about psychological safety.
Yeah.
Another interesting presentation to come. And now babble on until you share your presentation.
All right, hold on a second. Let's see.
That's my job, I think, today. Yeah.
All right. So we'll hear some thematic similarities to what we heard from Beatrice earlier. So I'm very excited that she and I are going to be doing this alongside each other. I'm Anna Weiss. I am by training a pediatric emergency medicine physician at the Children's Hospital of Philadelphia. And I'm also an associate program director in our residency program there. I am really excited to meet you all and to hear a bit about all of your work while I share some of my own planned work with this incredible supervisory team that you can see on the slide here. And I'll be talking about the idea of psychological safety in graduate medical education, specifically in the clinical learning environment.
Anna, I think we're seeing your presenter view and not.
Oh.
Maybe you should share the other screen. if you have two
I
screens.
did this talk at a different, let's see, I've done this talk in a different place, so I maybe even have the wrong, let's see which one I'm sharing with you.
And otherwise, otherwise I think you can just continue and nobody will be.
That work?
That's better.
Awesome. Excellent. All right, so our work really starts with this assumption that learning in the clinical workplace is a sort of inherently social, entirely context-dependent endeavor. And for the purposes of our program of research, we're going to be using Gruppin's framing and definition of the clinical learning environment, really as a sort of complex ecosystem of inter and intrapersonal and cultural and spatial and organizational factors that kind of all need to coalesce in order for learning in that clinical workplace to happen effectively. And one of the things that I've noticed both as a medical learner and now as someone who leads a medical education program is that we really started to see that that the structure and the practices of this clinical learning environment as a construct are sort of asking our trainees to do two opposing things. So we're asking them to be what our research team has called sort of be an authentic learner. We're also asking them to show everybody that they are a demonstrably competent clinician. And those two things I think we really feel are a bit at odds. I'll describe that a little bit more. So I think on one hand, we're saying, we want our trainees to be in an emotional state that allows them to do the cognitive work of acquiring knowledge. So that really means like embracing vulnerability, being willing to engage in learning behaviors like revealing gaps in your knowledge, asking for help and feedback, posing doubts and posing questions to your supervisors, right? So that's a one way of being that we're saying in order to learn, you have to participate and act in this particular way. And then on the other hand, we're saying the expectations and the structures and the sort of traditional relational components of the clinical learning environment usually are rewarding our trainees for doing sort of the opposite, right? So we're rewarding our trainees for demonstrating autonomy, for maximizing efficiency, and for telling us not what they don't know, but for showing us very much what they do know. And this gets a little bit to what Beatrice has started to talk about, right? So the existing literature on clinical supervision is quite clear that generally medical learners are very hesitant to engage in help seeking because they really don't want to undermine their supervisor's perceptions of their competence. And when we ask them about that, that's really because they are associating supervision with high stakes assessment rather than with a safe learning environment. And the trainee participants in these prior studies really acknowledge pretty openly, sort of similar to how they've been talking to Beatrice already, that like when they are unsure of something, they stage a performance rather than asking for help, because the perceived risk of admitting that you don't know something really is too great relative to the importance of looking like you know what you're doing in the clinical learning environment. This brings us to the idea of psychological safety, which is defined here as the belief that, specifically in a group context, that you will not be punished or humiliated for speaking up with ideas or questions or concerns or noting that you've made a mistake, and that this group environment is safe for interpersonal risk-taking. This was coined in 1999 by Amy Edmondson. And her work demonstrated that on psychologically safe work teams, and she looked not only at medical teams actually, but she did some of her original work was on medical teams specifically, that individuals on safe teams are willing to disclose their shortcomings and to engage in learning behaviors like feedback seeking, intellectual experimentation, open examination of their mistakes. And I think what's really interesting is it also demonstrated that team members who were sort of freed from the cognitive work associated with impression management, which we'll get to, really were freed to take interpersonal risks and as a result, they actually learned more quickly and they were able to acquire more knowledge. So our research team then has sort of posited that psychological safety may play a pivotal role really in mitigating this conundrum of being a graduate medical education learner. That is, like, if I'm in a clinical learning environment that is sufficiently psychologically safe, I can feel free both to I can hold both of these things at the same time, that I can engage in the work of authentic learning and I can advance towards being seen as a demonstrably competent clinician, because in this environment of psychological safety, I understand that part of being a fully legitimized physician is actually demonstrating a willingness to be wrong or to be vulnerable. But that takes a fair amount of belief and trust on the learner's part. So to explore this topic more in depth, we've proposed a series of what we think will be 4 studies with the overall goal of understanding sort of if and how the concept of psych safety affects the experience of our GME trainees in the clinical learning environment. And for us, graduate medical education trainees, for the purposes of these studies, are going to be resident physicians. The first study we've just completed is a scoping review of the literature of the concept of psychological safety in the GME workplace. Studies 2 and 3, we're hoping to think about both the intra, so within the individual person, and then interpersonal experience of psychological safety in the clinical learning environment. And then we're hoping at the end to move towards the faculty and their perceptions of the role of psychological safety in the clinical learning environment. And are you still seeing, because I switched to a different slide deck because I've done this before, are you still seeing my slides, or what are you seeing? Just a slide?
We're still seeing your slides.
Okay.
Yeah.
Just moved them over while we're talking. Excellent. So for, as I said, the scoping review itself is completed. We've sent in revisions for that one. And then for studies 2 and 3, we're thinking about, as we said, interpersonal and intrapersonal experience. So intrapersonal really is, what does it feel like to experience these simultaneous pressures of both, you're supposed to be engaging in intellectual humility, also you're supposed to be making sure that everybody around you sees you as competent. On the other side, what are the external factors acting on our trainees that really sort of shape their beliefs around who they're supposed to be in the learning environment? What are the social norms and expectations? What are kind of the structures and constructs of the clinical learning environment that are working on them to make it hard for them to demonstrate that vulnerability? And this brings us to the work that Beatrice has been doing with impression management, right? And again, this is the theory from Goffman, the idea that each of us, and I love that she also put masks on her slide, the idea that each of us has this sort of wardrobe of context-dependent masks that we're wearing in each of the settings that we inhabit. And these masks are really designed to sort of curate the information that others are getting to see about us and to manage the impression that others get of us when they are in our presence. This is not a pathologic thing to do. This is a normal human interaction. And when we engage in impression management, we're really sort of juggling on-stage and off-stage versions of ourselves. And we're really very selective about who gets to see which parts of us and when. And then when we think about this in the context of the idea of legitimate peripheral participation, which is the other way that we're going to be grounding this first set of studies, is really thinking about how trainees are very highly motivated to portray a picture of what they think of what they believe a fully legitimized physician should be. And so they're either going to hide parts of themselves or highlight others to sort of ensure that everybody else around them in the clinical learning environment is seeing them as progressing inward from the periphery of practice. So that's a sort of intrapersonal piece. And then thinking about the interpersonal experience, we're going to be looking at that through the lens of the concept of the hidden curriculum, really to start thinking about sort of what are the implicit academic and social and cultural messages that we are conveying to our trainees about who we think they're supposed to be in the clinical learning environment. And we suspect that these messages are really an important driver in our trainees' motivations to hide their shortcomings or to avoid asking us for help. And we expect that the presence or absence of psychological safety may actually be a key factor in whether an individual trainee is able to sort of safely challenge those implicit messages. So for this first, we've done, as we said, study 1. For this next set, we're going to do a series of interviews. We've proposed to study these interweaving concepts from a position of social constructionism. We're planning to gather data with one-on-one semi-structured interviews with resident trainees. We've planned this as a theory-informed inductive study informed by, as we said, impression management theory, the idea of legitimate peripheral participation, and then the concept of the hidden curriculum. We'll be recruiting resident trainees of all years from the Children's Hospital of Philadelphia, from the University of Cincinnati, and the University of Washington. And those residents will be in pediatrics, internal medicine, and emergency medicine, respectively. So far, we have IRB approval at all 3 of our sites. We've created and iterated now on an interview guide that is informed by both impression management theory and the hidden curriculum and the idea of legitimate peripheral participation. We've done some pilot interviews and have iterated on that interview guide based on their experiences there. And our next, we have IRB approval at one of our other 2 sites, but we're waiting for the IRB approval at the 3rd site. And then we'll start, oh, I see that I copied and pasted, but then we'll start doing, our plan is for the summer to move ahead with our actual interviews and then start as a team iteratively coding those and getting a sense of what it is that we're learning. And I will stop there. Oh, Renee is here. And so Stephanie, hi.
And Desiree. Thank you for that presentation. Who would like to ask a question? I see many. Beatrice, you go first.
That's a wonderful talk, Anna. And I love kind of how you said it. I love the psychological safety aspect of it. I think it's great. My question is, so you mentioned like intrapersonal, you mentioned interpersonal psychological safety. I feel like, and I'm not an expert in this, but there's like there's a lot of personality, personal characteristics, etc., playing into the psychological safety that someone feels. Which category would that be more in? Because I feel like I could see it in both.
Well, I think you're right. I think it is in both, right? But I think, and we've talked about this as a team as well, that there are going to be things, innate things about each individual that are going to affect how they are interacting with the environment and probably how they're metabolizing those messages that they think that they're perceiving when it comes to things like the hidden curriculum. And so I imagine that it is both things that sort of, if I don't know that we'll be able to pull those out necessarily in at least the way that our interview guide is currently structured. But if I say have particularly bad imposter syndrome, I imagine that sort of my experience of the hidden curriculum and the way that I manage the impression of others is going to be different. And I suspect that if I were a particularly confident individual, that would also go differently. See if I can see the chat.
Okay, thank you for your presentation. You mentioned the hidden curriculum. Do you see the existence of psychological safety as part of the hidden curriculum, or do you think that it should be part of the formal curriculum? So how do you see that?
I think it'll be interesting to see what our faculty think about that. I think for now, anecdotally, it's neither. I think that we are going to have to, I think it is, from my own experience and from talking to learners around us, I think it is quite absent from both the hidden and explicit formal curriculum at the moment. And one of the goal outcomes of this work would be to say, listen, how do we both pragmatically and formally institute some of the practices that we know are helpful in supporting psychological safety so that our trainees can actually do what we're asking them to do.
Yes, I think the feedback process on the psychological safety is very important in this. So I'm looking forward to your research.
I'm going to ask a question myself if I see no further hands.
I was thinking I can also ask a question otherwise. I have a small one.
Okay, go ahead.
I was just wondering, thank you for your presentation, by the way. It was very interesting. I was especially interested in what you mentioned, the balance students need to find between being an authentic learner and a competent clinician. And I noticed that in your entire story, you mentioned a couple concepts that were related a little bit to the self-determination theory. So relatedness, autonomy, and competence. And I was wondering if you have thought about this theory or how you can incorporate it a little bit in your studies.
I think that's a great point. It is one of the theories that we talked about when we were making decisions about how to ground this. I think that you're right. I think that's very much going to come up.
Yeah.
And we'll see when we see their stories whether in fact that's a better way to
Yeah, because I do know it's mostly used for motivational learning, I think. So I don't know if that's really connected to your topic, but I just noticed the terms.
To see sort of how much our trainees believe that they are in the driver's seat, which
Yeah.
I think may sway us one way or the other with regard to whether this is self-determination or this is really impression management.
Yes. Okay. Thank you.
I think my question was similar but different on a different aspect. A lot of that hidden curriculum is going to be very context dependent, I would say. And I remember particularly a conversation that we had with our master students here a few years ago, where we found out that in some parts of the world, if a resident asks a question, that's a sign that you have prepared well, that you're competent.
Yeah.
In other parts of the world, asking a question is a sign that you have not prepared and you're a bad student.
An idiot, yeah.
So I was wondering how you were going to deal with that context dependency of the hidden curriculum.
I think that's very important. It's one of the reasons why we're doing this in 3 different sites and in 3 different specialties. Also, very frankly, we very much liked working with our co-investigators at those 2 sites, and so we're also just excited to work with them. But I can tell you so we're doing pediatrics, emergency medicine, and internal medicine. And even at Children's Hospital of Philadelphia in our ED, for example, we have trainees who are in pediatrics and we have trainees who are in emergency medicine. And the emergency medicine trainees walk across the street and put on one set of masks, and then at the adult hospital, and then when they're on their pediatric rotation, they come over and they're very clear with us that they have to be a different human being when they're in the children's hospital than when they're in the adult hospital. And so I do think it'll be interesting to see if we can get them to articulate what those messages are, whether they're different by location and by specialty. Because I think you're exactly right.
Anybody else who has a question at this moment? Do you have a question for us, Anna? Challenging.
I don't think so. But
on my program, it says that we're going to have a break now. So I think, Joanne, maybe you could stop the recording for a minute. And we'll leave the microphones open to record. For those who joined later, very welcome. We have 2 presenters to go, and I'm going to invite Chris to share his slides. Chris Walinga, I just heard, is a general practitioner and also teaching in that field, and he's harvesting insights.
Right. Well, thank you all for having me. Let me first introduce myself. As I said in the break, I'm a GP by profession. I'm a GP for 15 years. I work in the beautiful city of The Hague. Also, since I started working as a GP, I'm an educator, now mostly focusing on coordinating the GP education within the undergraduate curriculum at Leiden University. You see a picture of where I work in Leiden. And of course, I'm an external PhD candidate now for 2 years. So it's been going on for quite a while now. And I'd like to present my proposal today, which revolves around collaborative reflection sessions. And those are a form of facilitated peer group reflection sessions that are organized during the GP clerkship throughout the Netherlands. So it's everywhere. And as a medical student, but also as a GP trainee, I took part in many of those sessions. I found them very instructive. As a medical education, I enjoy leading them. And now I have the privilege to research them, so that's great. Let's see. Move to the next slide. Yeah, so this is my team. On the left, you see Marlene Othoff. She's my co-supervisor at the LUMC. She's the head of the Students Education Department, and she's working as a GP. In the middle is Matthijs Numans, is a professor of general practice, also working as a GP. And on the right, you all know him, I guess, Pim Teunissen. with my supervisor at the. So let me tell you a little bit about the background of the topic. Why is it important to support student learning in the clinical placements? I think it's good to know it's not everywhere like that. In the Netherlands, the medical school consists of a bachelor's stage, which is mostly theoretical, and the clinical master phase is when you go into your clinical placements. And in the transition to that phase, students are enrolled in new environments, they have new roles, they encounter real patients, they have real responsibilities. And those are, of course, valuable learning opportunities, but students also find them very stressful. So while students are in the workplace, what can be our task as faculties to support the learning of medical students? Well, one thing we know from literature is to engage students in peer group reflection sessions. And one specific example is, of course, the collaborative reflection sessions that I'm researching. About the theoretical background, well, a few came by already. The community of practice, of course. In the collaborative reflection sessions, we may support or deepen the learning that students have from interacting in this community of practice. Of course, the self-determination theory already also addressed earlier with the three aspects of autonomy, relatedness, and competence, and maybe we can support those psychological needs within the collaborative reflection sessions. And on the right, you see the concept of professional identity formation, which is a social process, because learning in the clinical phase is not only about being competent or becoming competent, it's also about learning to think, act, and feel like a real physician. So in the collaborative reflection sessions, as we organize it, we try to support this process through dialogue and reflection. So, well, what are those sessions? I think it's most important to imagine. You see the picture. When I sit there as an educator, I just invite students to openly share any workplace experience that they might find relevant. So their learning need is central there, and they work together to make the session valuable to all. The students, they're in a fixed group since the beginning of the clinical phase, and it's led by an educator like myself who has a practical experience as well in general practice in my case. Regarding the format, there's no strict format. It's mandatory. It's a part of the educational program. So, but there's no assessment. I think that's an important part. And it's organized every 1 to 2 weeks. It depends on the location, but at Leiden it's every 2 weeks. At Maastricht is every week. But it's organized all throughout the Netherlands. So, and it's organized on site. So it's outside the clinical workplace that students go to. This slide is about the overarching aim that I have for my project. So we aim to better understand how these sessions support learning in the clinical phase. And we have 4 studies. The first I already completed in 23. And we explored the workplace experiences that students shared, what they perceived to learn, and how they perceived it to contribute to their professional development. The second study, we want to deepen that exploration by researching the contribution to motivation to learn and to personal and professional identity formation in the third study. And in the fourth study, we like to dive into more the role of the facilitator and how students and facilitators perceive those. This is the first study. We sent out questionnaires to 99 students in 11 groups. They had open-ended questions, Likert scale questions. We did it at the LUMC, and we performed a thematic analysis on the open questions and also analyzed the Likert scale questions, of course. Let me just shortly give you some of the results with regard to the shared experiences. They were often very complex, so it's not to be found in books. It's about difficult patient communication or issues with supervisors that they experience. What they learned, you can divide it into 2 main topics. The first is about the process of the professional development, about becoming a physician, through the social interaction, through sharing experiences, students had an opportunity for venting or for emotional support from each other. And with regard to the content of professional development, it's more about competence, like communication, getting tips for better communication with patients, but also cope with challenges in the workplace, or like being independent for the first time, or being inserted in medical decisions. And students perceive those sessions as highly safe. I think they meant highly psychologically safe. So it's they found it very helpful for their professional development. So this slide, I take the study 2 and 3 in one. It's just shown in one slide because it's as they have a similar design and they draw on the same data set. The design is a constructivist grounded theory, and we start by observation of the collaborative reflection sessions. Then we decide who we want to interview, like 3 to 4 students per group, and then we do it. We do it at the LUMC and at Maastricht. It's an iterative process, of course. After one group, we look into the data, we make adjustments, how we observe, and who we want to select for the next bit, and what changes we should make to the interview guide. So, and lastly, the 4th study, it's again an exploratory study. We want to dive into the facilitator's role, and because, for example, isn't important that the facilitator also has a background in general practice, and how do the students and the facilitators perceive that aspect to be important to their learning during the sessions. And we are planning to do interviews at 2 medical faculties again, and do a thematic analysis on those interviews. So I think that's it. Thank you for your attention. I will stop sharing now.
Thank you, Chris. I think we're definitely seeing a theme here. I'm looking for questions. Pascal, you may go.
Yes. Okay. Thanks. Thanks, Chris, for the great presentation. Sorry that I couldn't meet you at the SHE Academy, but now we meet online. Great to see you. Very nice topic. I was wondering, just a very short question. So we're talking about collaborative reflection sessions here. To what extent is this actually different from what we call peer consultation, or in Dutch, intervisie, intervision, freely translated, but that's not a real word. I'm sure. I think it's officially peer consultation, but I'm not sure. Daniela, do you know? Peer consultation.
Yeah, peer consultation.
Yeah. So, and which is quite structured. There are some structured approaches to that. To what extent is this collaborative reflection different from peer consultation?
Yeah, I think a few things. Is a very interesting question. We struggled with that as well within the team, or struggled. We talked about it, and I think firstly the intervision meetings, they are very structured, of course, and they are centered around one student. So the problem of one student, or the issue of one student, and all the participants help that particular student to get a further step. And in contrast to the collaborative reflection session, it's more, the aim is more, how can we have value for all participants? So and all the participants, they do work together. Like when a student shares a workplace experience, then it becomes of the whole group, and they decide what side is going to develop. Yeah. Like an end of life care issue. Is it because of emotions that it's so hard to cope with that, or is it, how does it work? What things do you need to think about when it occurs? So you decide together where the discussion goes to and what you can get out of it. So it's in that aspect it's different. I think the groups are smaller with intervision meetings, and they're not particularly organized during the placement. So they're organized less frequently, at least at Leiden University. So with the collaborative reflection sessions, students, they share their experience they have just experienced, like the week in advance or the week earlier, sorry. So I think it's more, yeah.
Okay.
Anything is welcome. Yeah, is it clear?
Yeah, that's clear. That's
We
clear.
also asked the students to elaborate on that. During the interviews that we now conducting, we asked students, do you see differences?
Yeah, okay. Thanks.
Jannie.
Yeah, I have a question. Is connected a little bit to the question of Pascal. Thank you, Chris, for your interesting presentation. And I think it's really, I wonder, what is your conclusion about this first study? I think it's, you tell us something about the collaborative reflections. The method, what you use is more free than intervision in the Dutch way. But I wonder, what is the way you get it, get everyone involved in this? I don't know. I don't. Maybe I have to read something more about your research. But
so your question is how to have the whole group. Yeah.
How do you get them all together to the same topic? Yeah.
Yeah, it's we ask the students and we select students from the students who are very on the foreground, but also students who just seem to listen or are disengaged, and how they experience those reflection rounds. So we try to gather different perspectives on that. And for instance, not actively sharing or just talking, contributing to the dialogue, does not mean that students do not learn. They actually, they say they do learn a lot. Yeah, and it's sometimes the beginning of a reflective process on the spot or in a later stage. But it's I think it's one of the maybe the weaknesses of this format is that that not per se everybody is stimulated to actively contribute. Sometimes as an educator, I do ask the silent students to contribute, and they almost every time have a very interesting contribution to the discussion. So that's something that our educators are also aware of. So we try to invite them. Yeah. So
yeah, but maybe I also want to know something about the level. So is it only the level of someone who want to bring a topic in, or is it a higher level thinking that you want to dismiss it to different situations? I think.
Yeah, I think the workplace experience, what we see now in our data, is that it serves like a vehicle to discuss something that is important for that particular student or for the group to discuss. So it goes to a higher level, but it's only 3 times during the GP clerkship. So and it's a free format. It's only an hour to an hour and a half. So maybe the results are limited, but it goes to a higher level. How can I react to supervisor? How do I survive my clerkships when I don't like it there? But even also self-regulatory things, like to keep yourself in the workplace doing the right thing. Yeah.
Yeah. Thank you. Yeah.
I guess that's also part of the role of the facilitator, no? To stimulate that level of discussion.
Yeah.
Or
right.
And then it'd be interesting in your last study to see then whether students and facilitators have the same expectations.
From postgraduates, we know that they are not only facilitators, but they also contribute from their practical experience as well, or just mingle into the discussion as a participant. So there are many roles that you can have as a teacher.
Any other questions for Chris at this moment? I'm seeing a definite theme for today's session anyway.
That's nice. Yeah.
Even though this is slightly coincidental, I think. Let's go to our last presenter of the day, Anna van Doorn. I see you there. Can I ask you to start sharing your slides?
Yes, of course.
Unraveling the digital landscape suggests that you might be talking about something completely different, but
yeah, I will.
We will see.
Okay, there we go. Yeah, so hi everybody, my name is Anna. I am studying how digital media use is related to the cognitive development of young adolescents. Lisbeth Kester is my main supervisor. I was originally working at the Department of Utrecht, University of Utrecht at the Department of Education, and also connected to the Department of Pedagogics there. So my research is very different from the medical education field, so I joined here in January. So I'm also still making a little bit of the switch of trying to understand what all the medical education research is about. But yeah, I hope that you will still find it interesting. So there we go. Digital media use at this moment, especially for children and adolescents, is a very hot topic in the mainstream media. There's a lot of news articles about it, for example, about the age limit of social media, the bans for social media use under 16-year-olds, for example, and the phone bans on schools. A little while ago, the Netflix show Adolescence has come out, and that's also been very much noted in the mainstream media. And Jonathan Haidt's book, The Anxious Generation, has been discussed a lot as well. This shows, especially, I think, that parents and schools don't really know what to do about digital media use in relation to adolescents and children. And there is a need for evidence-based guidelines to teach them and help them find a balance in what's healthy and what is unhealthy use. So it is important to find out how digital media use relates to children and adolescents' development, both positively and negatively, because it's not all bad, but it's also not all good. And therefore, we need to find out which factors are harmful and which might be beneficial. How can parents, teachers, and peers help each other? And which children and adolescents are more susceptible for negative effects? And these are all the questions that we aim to answer in our consortium. We have a very large consortium with 7 PhDs and 1 postdoc studying the digital media use in relation to development and equal opportunities. And therefore, we have a children's cohort studying cognitive, identity, and social developments, and an adolescents cohort studying the same developmental parts, and 1 PhD that studies equal opportunities for both children and adolescents. I am this part, the green part. I will be looking at the cognitive part, development of adolescents. So I will look at young adolescents and a bit mid-adolescents, 12 to 16-year-olds, and I will especially look at digital media activities, both long format, which is over 1,000 words or longer than 10 minutes, when you look at, for example, audiobooks or podcasts. And short format is less than 100,000 words and less than 10 minutes. And that's especially used on social media to engage engagement, because that's what they get money for, essentially. I will also look at executive functions. So I will look at attention and inhibition and working memory. And I will look at adolescent school grades, maths, Dutch, and English. I have based my study on the cognitive load theory by Sweller, which means that our brain has limited capacity to process information from messages in the environment. So to very uneloquently say, when too much information is presented at once, your brain might not be able to process all that information. And where digital media comes in is that digital media often offers fragmented information. So either adolescents will be both working on their homework and texting and listening to music, or on social media, when you're scrolling through TikTok, for example, you get very short videos constantly following each other up, offering different types of information. So that might overwhelm the brain, leaving little what was I saying? Leaving little capacity left for other information processing or learning. However, digital media is not inherently bad, also not inherently good. And a lot of studies focus specifically on screen time, which is not a very insightful variable either. So to illustrate both of these, looking at us, for example, we work on our laptops about 7 or 8 hours a day, depending also on if you have online meetings or offline meetings in person. And combine that with your phone use in between, you probably have a screen time that is over 8 hours a day, which is a lot. If we see that in studies, we say, oh, that's a lot of hours adolescents would spend on their devices. But that doesn't mean that it's necessarily bad, because we use our laptops for looking up information or for meetings. So it's not very insightful, neither just the screen time. The screen time is not very insightful. So we should better look at specific uses. So that's why I want to look at short form versus long form, because the short form activities mostly used for social media offer more fragmented use, and long form digital media use offers more opportunities for practicing executive functions. If you listen to a podcast or if you watch a film or a documentary, you need to activate your working memory, inhibition, and attention more than you do with social media use. Also, excessive and compulsive use, which is often described as addictive use, is only present in about 5% of the population, but that does show that a lot of the people using excessive or compulsive have more problematic relationships. So the studies that I will be conducting during my PhD, the first one is a cross-sectional study. We have just completed the data collection for that. And I will be studying in this one what the relationship is between digital media activities, both short and long form, and executive functions, and how digital distractions might play a role into that relationship. So how do digital distractions mediate that relationship? This is also the first wave of a longitudinal study that I will be mentioning last. My second study that I'm just setting up is a focus group study, because I think it's important to also talk to the population itself rather than just us thinking what is important for them. I will be talking to adolescents about the distractions that they find from digital media and which strategies they think would be helpful in managing these distractions. Focusing, for example, on what can parents, teachers, and peers do, or what are things that you like, can you put your phone away, that kind of stuff. And then based on the strategies that they mentioned, I want to do another studying in which adolescents can test out a couple of these strategies. And I would love for that to be a mixed methods study with both a questionnaire, like do they actually have improvements, self-perceived improvements in executive functioning? And how did they find the strategies? Are they feasible? Are they fun to do as well? And that with the diary study. And then, as said, the last study will be a longitudinal study on the relationship between digital media use and the cognitive development of adolescents, so executive functions and school grades. And then I have so many other ideas for possible studies that I probably won't have time for, but that I would love to do. So that was, in short, my PhD plan. Any questions?
Thank you, Anna. Any questions for Anna? I can tell you, Anna, that as the parent of a now just 18-year-old, I struggled with that. Certainly also with the fact that the school banned phones after all the stakeholders had said that they didn't want that.
Yeah, I find that really interesting as well. And another thing that I find really interesting is that Jonathan Haidt is being invited into the Netherlands government, etc. While we have a lot of Dutch researchers studying these topics that say this is not a really feasible or realistic study that he's done. So yeah, it's important to note that there are bad things, but also a lot of good things about digital media, and we need to find the balance.
Anna, the other Anna, you have a question.
I love this, Anna. I think this is so exciting. I am also, in addition to being a pediatrician, also the parent of a 15-year-old. So I also think that this is really important. And I agree with you. This is a little bit like, I think Jonathan Haidt's work is a little bit like the just say no approach to drugs, right? Like that's just not a reasonable approach to adolescence. We know that. And I was curious, since you're grounding some of this in cognitive load theory, whether you're using, we talked about executive functioning, but less about sort of the translation from working to long-term memory that's in cognitive load theory. And I wonder whether you're thinking about using sort of school grades as a proxy for whether students are able to consolidate long-term memory when they're also on their phones.
Yeah, the idea is indeed to follow grades with that perspective in mind. Of course, it's not really the same, but it's really hard to measure long-term memory in any way, especially with questionnaires. So this is how I hoped to capture some of that. Yeah.
Tim.
Yes, Anna, thank you for your presentation and very much welcome to Health Professions Education.
Thank you.
I'm sure that your findings are relevant to the 17, 18, 19-year-old students who start any type of health professions education. Now, I have a question around the choice for cognitive load theory, because in a way, that approach leads you to see distractions as in competition with other forms of attention that students need to pay to whatever the education is presenting to them. And I see that also in the way you framed the first two research questions. You talk about digital distractions. Did you consider other ways of cognitive concepts that, for instance, look at more the plasticity of the brain and the way in which digital stimuli might help students develop different ways of paying attention to information?
Yes, yeah, so we do also plan to really look at the positive things as well, because it is true. For example, a lot of video games might enhance cognitive skills. They've already found that video games can enhance cognitive flexibility, for example. So I definitely want to incorporate also not just looking at the bad things and how does it distract, but yeah, I saw your like off, but also what might actually be beneficial. So playing video games for a longer time might actually be beneficial, or like I said, watching movies might be beneficial for attention and inhibition and working memory. We don't.
And do you think cognitive load theory is helpful if you want to take that approach? Do you see it being applicable then too?
Yeah, that's a good question. There might even be better theories. I can try and find that out. Or if someone has a suggestion, I'm very open to hearing that as well.
Yeah, I'm not trying to give sort of implicit feedback that it's not applicable, but I do recognize that because it considers our working memory as limited, which is reasonable, you often get into a conversation around competing demands on the brain. And I just want to highlight, it's not the only way of thinking about how the brain works, and especially not how the brain develops during adolescence.
Yeah, that was a very good point.
Very interesting.
Thank you.
It made me think of metacognitive skills and how it might improve your planning or your attention direction, which is not specifically visible in cognitive load theory.
Yeah.
But anyway, yeah. Pascal.
Yeah, just to also connect to this discussion, which just, popped up in my mind. There's this multimedia learning theory by Richard Mayer, which is quite a classic. I'm not sure whether this is still developed, which may be applicable here. I'm not sure whether you looked into that one.
Yeah, I think I've seen it because a lot of the studies looking at media multitasking take this approach, but
Yeah.
I don't specifically look at multitasking. So I only have information about which activities do they do, but not which activities do they do at the same time.
Okay. I was also wondering, and that was my initial question actually. So cognitive development is one thing, but mental health is the other thing. And I think this
Yes.
Jonathan Haidt, I'm not sure how you pronounce his name, is especially concerned about mental health, right? Not so much cognitive development.
Yes.
So I'm really wondering what your thought is about that. Do you include it in your study as well?
Yeah, so I have one of my colleague PhDs is looking specifically at the social development of adolescents, and she's incorporating also mental health. And another of my colleagues is looking at the identity, and she also takes a part of the mental health into account.
Okay, so they mutually, yeah.
Yeah, so hopefully at the end, when we're all done, we have a nice package of information to offer. Great. We also plan, if we have time, to do one study with the three of us together. But we need to see how we can set that up, because it's of course nice to offer schools or parents also a picture of the entire development.
In that regard, I was also wondering, Jonathan Haidt, I think he was interviewed by this organization that I'm familiar with. It's called Center for Humane Technology. I'm not sure whether you've ever heard of that organization. It's an organization that is really, they actually are behind The Social Dilemma, the movie. I'm not sure whether you're familiar with that movie. And they do a lot of great work also in relation to cognitive development, but also mental health issues in young people, adolescents. And they actually have a very positive approach to that. They, on the one hand, they warn against, developments like social media, artificial intelligence, stuff like that. On the other hand, they have suggestions how to deal with this as schools, as parents, and maybe helpful to look into.
Yeah, thank you. That's great.
Yeah, humane technology. So not human technology, but humane technology.
Yes.
Yeah.
Okay, great. Thank you.
Yeah, and I see you have a question.
Hi, I'm curious about your first study, and I saw you're going to have maybe a quantitative research. So what kind of analysis you're going to have for using maybe survey data? Maybe,
yes, I'll be using. Yeah, I'll be using survey data, and I'll do a moderation analysis or mediation analysis using structural equation modeling, path modeling, basically.
Okay, thank you.
No problem, thanks.
Any other questions for Anna? I second that idea that social media also can have positive effects. Also on mental health, I think, as the parent of a queer child, I know that she has her community there. So I'm very happy that you're looking at both sides in your research.
Yeah, thank you.
If there are no further questions, I'm going to close this session, or at least I think we can stop recording.